Welcome back to Managing the Problems of Daily Living. We're honored today to have Dr. Joel Young, a psychiatrist with a private practice in Rochester, and the name of the group is?
Rochester Center for Behavioral Medicine.
A big group with lots of opportunities to be treated. And Dr. Young has been with us previously. He is currently working on a new book called A Practical Guide to Chronic Fatigue, and it's going to be published in 2020. So we are on the newish side of this pre-publication of this publication. Before we get to chronic fatigue, Dr. Young and I were talking in the green room about kind of this epidemic of mass shootings. And because you're a psychiatrist and an expert in mental health, what are your thoughts about, why we're seeing more and more of these?
Yeah, well, Linda, thank you for having me again.
It's our pleasure.
I think it's an important forum to be able to talk about these issues. Mental health issues are always in the news. Rarely a day goes by where people are not concerned about these issues of mental health, suicide, and whatever shooting of the week it seems to be. It does seem to be epidemic at this point. And of course, it has unleashed a huge national debate about what should we do. What type of gun laws should we have, and the issue that's been raised even by the president about what's the role of mental health in these individuals who are shooters. And I think it's a complicated story, Certainly there's a lot of people with major mental illness. Major mental illness we refer to as schizophrenia or bipolar disorder. And statistics show that population may not be at any greater risk for mass shootings. Nonetheless, if you look at the profiles of some of the perpetrators, they do have some issues with mental health, and although we don't want to stigmatize anybody with mental health, we have to be realistic that there might be some things that we can do.
Or people, as you were indicating in the green room, and you and I know, are falling through the cracks. They're not getting the treatment that they need. They're being misdiagnosed. Something's missing. We're not kind of reaching different elements of people, different populations that we need to assess and treat.
Well, I think it starts early on. I think that we have a shortage of child psychiatrists and providers, and really I think in an ideal world we have psychiatrists and child psychologists more available, maybe even available to a school, certainly to districts, and I think that would really be helpful. And to me,
have eyes and ears on more people watching for certain signs and symptoms.
Yeah, and being resources
and behaviors, and be resources
to other professionals. I think that would be really helpful. I think as I look at this huge problem, I think what can we do? And there are millions of weapons on the streets today. I think even if we started some way of buyback or some type of reduction in the availability of weapons, which is controversial in and of itself, I think that would take a long time, and it may not even have a huge impact on what's been going on. What can we do? I think if we have mental health professionals available to teachers and to school counselors, I think we can intervene earlier and help a lot of these folks. We know that many of these young men have had problems with antisocial personality disorder. Some of them have been on the autism spectrum. Some have had untreated attention deficit hyperactivity disorder. They have a lot of impulse discontrol. When people are in a severe state of depression, they are more prone to act out and act in an antisocial way. So these are all complicated issues, but there probably is a role for people like you and me to help these folks.
I hope so. I hope so. I mean, I believe that. But oftentimes, family members have arsenals of weaponry in their homes, and the parents or their friends don't know about it. So,
Well, we're hearing those stories, right? These are incredulous stories where
Yeah.
you hear of a 17-year-old who's stockpiled weapons and nobody knows. And in fact, there's no
Yes,
way
we need to pay more attention.
we need to pay more attention.
And if your child is isolated and says he's okay, maybe not take that as an answer
Right, right. And
at face value.
and reach out and reach out. And it is a paradox because we are living in a social media world where people seem to have little inhibition about posting everything about themselves online. And we know that individuals are posting some of their violent intent, and I think there's no way of guarding against it, but I think as a community, certainly within the family, we should be aware of what's going on, and if the family fails at doing that, the community should also be aware.
Right.
I do think that, relevant to some of the things we talked about last time, Linda, there's a certain subgroup of kids that might be characteristic, and I think some of them are alienated. I think there are those that have been perhaps bullied, or those really without a lot of social engagement. And I think we should be sympathetic to those kids, and really double our efforts.
Prophylactically,
Yeah.
for sure. We just have a couple minutes left in terms of this break. We're going to continue the conversation with Dr. Young and talk about chronic fatigue. Why don't we start with the definition, and we'll follow up with the content of your new book when we return. So when we're defining chronic fatigue, what is that?
So chronic fatigue is defined by the Center for Disease Control as a disorder of excessive tiredness, sometimes with exertion, to the point that it's interfering with individuals' lives. And it is an orphan illness. There's no real treatments, but I think it's quite a debilitating disorder. I've been interested in treating it throughout my career, and my book, which will come out next year, really outlines approaches.
What compelled you to write the book? You had a number of people with this issue?
Yes, yes. So that's true. I had many patients over the years who have chronic, unrelenting fatigue. They wake up in the morning with unrefreshed sleep, and there doesn't seem to be a good medical explanation. These are folks that have been worked up by their medical doctors. They've been worked up sometimes by endocrinologists. They've been worked up by sleep disorder specialists and infectious disease specialists, and people don't get a handle as to why this persistent, unrelenting fatigue occurs. I have some ideas. I've actually had some treatment success. My book outlines a clinical trial that was done, and I'm happy to discuss that.
That's great. What percentage of people do you think are suffering from this particular
Millions.
disorder?
The CDC thinks millions, maybe 2 or 3% of the
And it's
population.
undiagnosed. They just think they're
You know, this is
lazy, they're not getting enough sleep. How do people interpret that?
Yes. So this is a disorder that affects women more than men. It typically occurs in maybe the 3rd or 4th decade of life. And many folks are really asking for input. They're doctoring a lot. Sometimes they go to traditional medicine. When traditional medicine fails, they often go to untraditional medicine. And they are viewed as psychosomatic. They're
Correct.
often viewed as hypochondriacal. And sometimes they feel dismissed and marginalized. And that's really not the message I want to send. I actually have some ideas about who these people are, what their pre-existing histories might be, and maybe some novel interventions.
Well, we will continue with that conversation after the break. I am curious about, what the profiles are for individuals with chronic fatigue, because I think it can also be a result or a consequence of an illness, of treatment for an illness, probably of trauma, of depression. Yeah, so we would have to figure out, I guess, tease out the particulars of chronic fatigue and treat that.
Let's talk about it.
Let's talk about it, and we will be back.
Mental health disorders are serious and treatable conditions. Isolation, loneliness, and changes in behavior could be signs that someone you know is suffering from depression. Learn how to recognize when family or friends are in crisis and what you can do to help. Mental health does matter. Contact the Resource and Crisis Helpline with your concerns at 1-800-231-1127.
Welcome back to Managing the Problems of Daily Living. We are honored today to be meeting with Dr. Joel Young, who is the medical director of the Rochester Center for Behavioral Medicine.
You got it.
Thank you. And he is in the process of completing a new book on chronic fatigue that will be available in 2020. So before the break, we had just started to learn sort of what chronic fatigue is. So who gets chronic fatigue? What is the patient profile?
Yeah. Well, so it's quite interesting because it's out there. There's not one specialty in medicine that's taking ownership of chronic fatigue syndrome. In fact, most people with chronic fatigue syndrome actually feel like people are abandoning them. They really can't find somebody interested to take care of them. I'll tell you how I got interested in it. It was totally by serendipity. As you know from our previous discussions, I'm particularly interested in the disorder of attention deficit hyperactivity disorder, which, as you know, is a disorder that starts in childhood. It's one of the few psychiatric disorders that starts in childhood and lasts throughout one's life. Now, it looks different in a 6-year-old than it does in a 16-year-old, and it looks different in a 16-year-old than it looks in a 46-year-old. Well, there are 3 major types of ADHD. There's one that we all know about is ADHD hyperactive type, when we think of a 6-year-old boy who really can't settle down and is bouncing off the walls. And that's everyone's kind of instant thought of what ADHD is. Turns out, more commonly, we have something called ADHD inattentive type. And people with inattentive ADHD have trouble focusing, they have trouble concentrating, but they're not hyperactive. And most girls who have ADHD have the inattentive form, and about 60% of boys who have ADHD also have the inattentive form. What's interesting is these boys and girls and adolescents become adults with ADHD. And it's this transition to adulthood that has really been my interest. So although I'm interested in ADHD, I am a trained geriatric psychiatrist. So I am interested in lifespan disorders. Turns out, having done this now for 30 years, I've watched a lot of people grow up. I've taken care of a lot of people throughout their life. And a number of the individuals with inattentive ADHD, more so than the folks with hyperactive ADHD, develop this chronic fatigue syndrome. They report that they are tired all the time. They report that they have a hard time getting going in the morning. They report that their motivation isn't where it needs to be. They start projects, but they don't finish projects. And they're lethargic. They often have been to their primary care doctor. The primary care doctor does a full workup. They make sure that they're not hypothyroid, low thyroid, they're not anemic. Sometimes they're sent to sleep specialists, sometimes they're sent to infectious disease specialists, but nobody can really get a handle on why they're fatigued. And in the course of my years doing this, working in Birmingham and Rochester Hills as a psychiatrist, those that had inattentive ADHD, I would continue to treat with ADHD medications, and I found that the fatigue diminished significantly. Not only was there less fatigue and less impaired motivation, but a number of these folks also had some chronic pain syndrome associated with their fatigue. And what I found is that, and what I suspected is that by treating the underlying ADHD, not only was there improvement in fatigue, Linda, but there was also improvement in chronic pain. Now, this is an important finding.
But they're 2 separate entities, the fatigue and the pain.
Although they go hand in hand.
Because I was going to ask you, do people complain of aches and pains?
They do. So sometimes we call these folks chronic fatigue syndrome if they complain primarily of fatigue. And the sister population to that might be people with fibromyalgia. And they have persistent aches and pains. Now, interestingly enough, there are some approved medications for fibromyalgia, but there are no approved medications for chronic fatigue syndrome. So having had this success, or at least anecdotal success, I organized a clinical trial using a known ADHD medication called lisdexamfetamine, and I studied and published a small trial of individuals with chronic fatigue syndrome. And half of them were given this medication called LDX, which is now commercially available, and another were given placebo. And what we found is that those that were treated with the ADHD medicine did have improvements in their chronic fatigue. They had improvements in certain aspects of pain and fibromyalgia scales, and they actually had less anxiety. So I want to emphasize to everyone listening that this is not an FDA-approved treatment. It is only an approved treatment for ADHD, not for chronic fatigue syndrome. So I really don't want to get ahead of it. But I published the book. I'm publishing the book because I do feel that there's a lot of people suffering, and I want to give people hope and actually express to them some of the clinical success that I've had.
Is chronic fatigue in the Diagnostic and Statistical Manual of
Interesting
Psychiatric
question.
Disorders? Yeah.
It's not considered a psychiatric disorder. In my hypothesis, chronic fatigue syndrome represents a number of people with ADHD grown up. ADHD, of course, is in the DSM. Chronic fatigue is not. It is an ICD. It is recognized as International Classification of Disease. It's recognized by the Centers for Disease Study. They consider it an orphan illness. They want more research in this. So it's not considered a psychiatric disorder.
I was going to ask you, sometimes I get referrals from neurologists for conversion disorders, which are the result of, if they can't find an organic reason, some underlying psychological issue that's creating a somatic complaint.
So this is conversion disorder is something that you and I, as a psychologist and psychiatrist, will see every now and then. And conversion, the literature on conversion disorders is actually quite interesting. Everyone has had a fascinating case of conversion in their career. And so the theory of conversion is that somebody is psychologically traumatized. Say they see a fight and somebody gets hurt with a right punch. Having witnessed it, they lose strength in their right arm, and that is known as conversion disorder. Well, it turns out when you see these folks, many times you really can't find the psychological trauma, but they have just functional deficits. People with chronic fatigue syndrome are
And there's no organic, I mean, I see people after they've been to every doctor.
Every doctor, in fact, they end up at Beaumont, they end up at the University of Michigan, they end up at Mayo, they end up in Lourdes. They are really seeking help. And along the way, they're often diagnosed with a number of medical conditions that just don't pan out as well. So these are folks who might be diagnosed with multiple sclerosis, but when their brain is examined using newer technologies, there's no real evidence of it, even though they might have a historical diagnosis. They're often diagnosed with rheumatological diseases like lupus or rheumatoid arthritis. They're often diagnosed with a psychological condition like conversion. They actually might be diagnosed with disorders like irritable bowel syndrome or premenstrual dysphoric disorder. They can actually garner diagnosis for every doctor they see. They're very frustrated people.
Well, that's what I wanted to get to, because we're a psychological, the program is how to manage. So when people are getting these diagnoses specific to chronic fatigue and then the kind of constellation of other diagnoses, what is the effect on the patients when you see them? They've been to a million doctors, they've tried different treatments. You alluded to the idea of even sort of seeking out wherever, far-flung parts of the country or the world. What do they look like to you at that point?
Well, I think they look defeated. They feel marginalized. They feel like people aren't taking them seriously. They feel dismissed. And interestingly enough, when I talk to doctors, that's not probably a misperception. What I've noticed about doctors is they like to get things done. They really don't want to swing and miss. And so when they have patients where they can't find a good answer, nobody likes that. Nobody wants not to help, particularly people in the health field. And sometimes the doctors will say, there is nothing more I can do. I'm a gastroenterologist, and I can tell you this one thing, that you don't have a GI problem. I'm a neurologist, and I can tell you this one thing, you don't have a neurological problem. I don't know what you have, but you don't have what I specialize in. So I agree with you, Linda. What's going on for these people is really interesting. Many of them feel just very depressed, very frustrated, and left behind.
Well, I think in the origin of some of these issues, I brought up conversion disorder, but the female hysteric, right? And I think it coincides with one's menses. Traditionally, mental health workers kind of saw people, particularly women,
Right.
With anxiety-related physical problems. So I think that is still a bias. I just happen to know about cystitis, which is a urinary tract disorder that, that really wasn't validated for a long time, that it really wasn't happening. Because maybe the doctors couldn't find a reason for it, or they maybe didn't know how to treat it at the time. I really don't know.
So cystitis, interstitial cystitis, is a classic example of this, and I agree with every word that you said. So this is a disorder of painful urination. Sometimes it can be pain during sexual intercourse as well.
Called honeymoon bladder.
Could be honeymoon bladder, yes. So over the years, it's a number of different things. And urologists are, although very well-meaning, when they examine the bladder macroscopically, when they look at slides of the bladder, they can't find anything wrong, yet the patient has persistent problems.
Correct.
So this is exactly the kind of disorder that I think is quite interesting, because there is no question that a number of women are complaining of this condition. And they're all valid people. None of them are hysterical. They're just people trying to feel better so they can live their lives and work their jobs and raise their families. They're
not making it up.
They are not making it up at all. And so this argument is that many of them have a latent problem with attention and focus. And they have trouble filtering out painful stimuli. And what we found with this clinical trial was this medicine, which we know helps people focus in ADHD, also helps folks with chronic fatigue. And what does it do? It allows them to filter out painful stimuli. It doesn't treat the problem at its root. It changes the way they perceive their pain. So just like when you get a mosquito bite, it's very small, the mosquito bite, but the way we kind of treat it is by rubbing our entire arm. That's a way of filtering out the specific pain. Whenever we get injured, that's what we do. And so the goal, and what seemed to work in this one study that we did, and it needs to be replicated, and I would like it, my goal is for this to become a national multi-centered study. I can't say I've gotten there yet, but this is a good place to air my frustration. I would like to do that. But in our single site study, we found that people on this medicine who had these somatic concerns, these bodily concerns like cystitis, were able to filter out their pain, and their pain scales actually went down. So this is important.
So they were able to get relief from their symptoms, their painful symptoms.
Their painful symptoms and their fatigue symptoms, which in many of these
And they were
patients,
validated, to use our language, right? Because then they weren't being told this is all in their head.
Yeah.
If the medications worked because there was a physical concern.
There was a physical concern, and unlike,
physical issue.
Unlike an opiate, which treats in the brain in a manner that we are really moving away from because of this opiate crisis in this country. Why I think this is an appealing approach is because it is a way of treating fatigue and pain, but not using opiates in doing so.
That's good news.
So but it's not obviously treatment for post-operative pain or cancer pain or crushing
Well, I
injuries.
think that was one of the questions I had, because you talk to people, let's say post-cancer treatment,
Yeah.
so they've had radiation and chemo, and they find themselves post-treatment super tired, like
Yeah.
unable to move. And how do you respond to that? There could be a depressive overlay, right? People could be depressed. They've just been through traumatic treatment.
Yes, yes. Well, that could be depression. I think some of the tools that you use in your daily practice, like psychotherapy, can be helpful. Sometimes those folks would respond favorably to an antidepressant, particularly if they have a history
I agree.
of depression. But
And I'm not big on pushing meds, but I think that sometimes the trauma is so impactful for people.
Right.
And they need a break. They need a respite from their symptoms.
However, in the patient population that you describe are people who've had cancer, and it's a slightly different population that I'm talking about. I'm talking about people who don't have an obvious
I understand.
provocative health concern.
So if people came to your office, you would be able to discern the differences.
Oh, absolutely.
Yeah.
And that would be, an important part of our diagnostic process.
And I'm sure as part of your trials, you have specific checklists in terms of a symptom list
Absolutely.
for people to be recognized. I'm wondering, are you going to be then promoting chronic fatigue as a diagnosis category in the future?
Well, it is, again, it's actually not in, as you mentioned, Linda, in the Diagnostic and
DSM.
Statistical Manual. So it's not officially a psychiatric disorder. It is listed in the International Classification of Diseases. My goal, really, I go to work every day because I want to relieve suffering, and I have a certain skill set that allows me to do that. And I take that seriously, and I know you as well. So my goal and part of this program is to let people know that people are thinking about their concerns.
That this is available for them.
This is available for them, but I want to emphasize that this is not yet an FDA-approved treatment.
We got it. Typically, I ask about a future focus. We just have a minute left.
Sure. A future focus? So, a future focus. Well, I'm always am committed to the mental health of folks in the Oakland County area. I'm particularly interested in these concerns about attention deficit and treatment-resistant depression. When my book comes out, I'm going to continue to talk about chronic fatigue syndrome because it's a segment of the population that I think is long suffering, and I think there are some good, solid, efficacious answers.
I believe you. We need to close, but we want to thank you for your continued evolution, Dr. Young, and continuing to strive to help more and more people with these different areas
Thank you for giving
of
me a
concern.
forum.
Of course. Thanks for coming.